Hello and welcome. My name is Raj Persaud and I'm a psychiatrist based in London. And this is part of a series we're calling Headstarters, where I'm in conversation with young psychiatrists, psychiatrists in training, about what it's like to choose psychiatry as a career. And we're in conversation today with Amanda and Aria. And I'm going to start by asking a little bit about how Amanda and Aria found out about what it's like to be a psychiatrist before actually starting to be psychiatrists. I'm asking this because I think psychiatry is a particularly difficult subject or discipline to find out about before you start doing it, because there's a kind of taboo around the intimacy of the consulting room. And I personally don't think you really get to understand what it's like to be a psychiatrist, maybe until many years after starting doing the training. But what are your thoughts, Aria, about that? And how did you find out about what it was like to be a psychiatrist before you started doing it? And was it at all accurate, your understanding?
Hello, Raj. It's a very good question, actually. The short answer is no, it wasn't accurate at all. Just going back to a bit of detail about how I found out about psychiatry. I would say the I, I would say the biggest influence I had for psychiatry was actually in medical school itself. However, I did have a little bit of idea about psychiatry just from what I saw as I was growing up. And I guess I should mention that I did grow up in a developing country where psychiatry is a big taboo subject. You will hardly see patients who with a psychiatric diagnosis, and you definitely didn't see many patients with psychotropic medications on a day-to-day basis. So coming across a psychiatric patient was not very common unless they were very unwell, in other words, acutely psychotic or was very depressed. So my impression of psychiatry before I went into medical school was this very unwell patients who were not in touch with reality. So my perception of psychiatry before medical school was completely unreal to what it actually is. When I was in medical school, which was in Southampton, I guess I got to grips with a bit more about what psychiatry is really like. But again, it was very different to what working in psychiatry is like. And coming back to your point, over the years, my perception or impression of psychiatry is changing. I think more and more I'm realizing the impact it has on people and their relatives. And actually the fact that there's a lot as a psychiatrist we can do for our patients, which is very different to the impression I had before I came to medical school, where all I saw was very unwell patients who were probably treatment resistant or undertreated.
I think from my point of view, I think I, like Aria, really didn't know very much about psychiatry before doing it at medical school. And certainly before I went to medical school, I really had no idea that you even had to be a doctor to do psychiatry. And I think I probably had a very similar perception to a lot of other people, or idea to a lot of other people, that actually there isn't much difference between a psychiatrist and a psychologist, and what that difference wasn't really apparent to me before going to medical school. But I think I would kind of disagree to some extent with both of your points, really, about not really knowing not being able to get an idea of what a psychiatrist is until you've been doing it in training for a few years. Because actually psychiatry, as a medical student, you actually get to do a lot of the things that you would as a consultant, as in the bread and butter. You get to speak to your patients, or the patients of the consultant that you're working with, and you get to have that kind of build that sort of therapeutic alliance with them. Whereas actually in other specialties, you're not doing anything at all like the specialty. For example, in I don't know, neurosurgery, you don't even get anywhere
Near the
close
patient.
to doing that as a medical student, do you? So it's actually wildly different being a medical student to being a neurosurgical consultant, whereas actually from going from medical school to being a consultant psychiatrist, in terms of what you have the opportunity to do and witness, it isn't as different, I don't think, as suggested, really.
But what I think is different, Amanda, is that I think most people may not know exactly what a neurosurgeon does, but they have some understanding of the kind of disorders that neurosurgeons treat and some notion of how a neurosurgeon gets someone better. So to take an example, I've just come from a clinic where I saw someone who was actively suicidal. And in terms of my assessment of that person and the work that I did with them and the fact that I didn't think they needed to come into hospital immediately, I think that kind of subtlety of what goes on in the intimacy of human communication is much more difficult for an external observer to get a sense of. And that's why I think psychiatry is particularly difficult as a subject to understand what goes on, because it's within the intimacy of a conversation or a contact between two people, and that's more difficult to observe.
Yeah, I definitely agree with that. And actually, I think one of the things that kind of surprised me when I started doing psychiatry after qualifying was actually how much kind of risk to self was kind of it was possible to manage in the community, where if somebody said that they were thinking about killing themselves, then I would my initial thought was, oh goodness, perhaps you need to come into hospital, when actually that's not the case at all. And actually I think I was quite surprised about that kind of aspect to practice and how much we relied on that.
And I guess that's the biggest difference, isn't it? Because I remember even when I was F2, seeing patients would come in after an overdose, and when they're discharged by the liaison psychiatry team, wondering how are they managing this patient in the community when they just try to, end their life. But obviously, now being a psychiatry trainee, I fully see how we do that. So that is, I guess that's what I mean by thinking. I don't think I had a grasp of that more subtleties of risk assessment and actually the subtleties of building that therapeutic relationship, because I guess it differs depending on your experience as a medical student and where you have that experience. But I didn't actually get to see a patient over and over again. I would have had one conversation with a patient and then presented that history to a consultant, and that would have been it. And I don't think that's very different to seeing a patient 2 or 3 times and actually really getting to know the patient, which is what happens when you're a trainee.
I think it also depends on your experience as a medical student, because I was on a kind of low secure unit where actually the turnover of patients was very slow, and we did get to see people on multiple occasions during their inpatient stay, and obviously not for the duration that you do as a trainee, but you did get some. I think you did get some insight into actually how the relationship develops over time.
Yeah, and I did it with a CAMS outpatient clinic, so obviously it was very different.
Yeah.
A lot of young doctors or medical students or people studying A-levels in the sixth form say that watching a TV series like ER, let's say, was kind of influential and got them interested and excited in medicine. Was there any television program or media experience or any book you read, either of you, which was influential? Or, I mean, I'm thinking of before you got to medical school.
To be honest, before I got to medical school, I hadn't even considered doing psychiatry at all, really. So I can't think of anything particularly. The only program that I used to watch as psychiatrist in was Frasier, which is brilliant, but not an accurate reflection, I think, of what psychiatrists actually do. And actually, it probably adds to the perception of of what a psychiatrist is that I had before going to medical school, that it was like a old guy who was really sort of into the arts and not really particularly medical. So yeah, I wouldn't say that particularly influenced me to go into psychiatry, but I think it probably does add to a societal view of what is a psychiatrist.
But was Fraser influential? In other words, did it have an impact on you? Did it shape your understanding before you made contact with the real deal, as it were?
To be honest, I think Fraser is quite far from what psychiatry is really, and given that I don't think I even realised that he was, well, no, I must have known he was a medical doctor. I don't know. I don't think that or the programme particularly influenced me in that way, to be honest. I think probably my influences were much more from people that I'd seen during medical school, like patients that I'd seen, and rather than actually a TV series, which I think probably isn't a very good reflection necessarily of a specialty.
Aria, were you influenced by anything on television or any book you'd read or anything else?
No, definitely not. I mean, like Amy, I wasn't sure if I wanted to do psychiatry when I entered medical school. I'd seen Fraser, but I guess I kind of knew it wasn't nowhere near what the real world of psychiatry is like.
But one of the things that you mentioned, Aria, was seeing people who are seriously unwell. You're coming from a developing country. I'm interested in both of yours impression of the coercive element of psychiatry, because that's where it differs a lot from the rest of medicine, and the popular stereotype of the men in white coats carting people off to an institution. Did that put you off, or was that a very surprising thing when you actually entered the field as to how that was different from the stereotype?
Well, for me, I guess one of the good things about having a psychiatry attachment in medical school is you get to see firsthand it's nothing like it. And I guess I knew that psychiatry actually was not like what you see in One Flew Over the Cuckoo's Nest. So even though that is the media portrayal of psychiatry, I guess hearts of hearts, I knew it was not like that. And as I mentioned, I'd seen the very unwell patient, but even then, in a developing country, I had not seen that men in white coats, taking patients into ECT kind of scenario. What interested me was obviously seeing how distressed the patients were. And I guess I felt like there was a lot to do, and maybe I could do a lot more help, or I could help the patients a lot more, if that makes any sense.
I do think there is something about psychiatry having a coercive nature, though, and I think at medical school, having the medical school experience that I had, I was quite surprised about how many sort of locked doors there were and kind of restrictions on people's movements when they were inpatients on this particular ward. And even now, I do think it is quite a kind of uncomfortable thing to detain someone under the Mental Health Act or to make those sorts of judgments, because I still do feel uncomfortable about it, actually, because it is depriving somebody of their liberty to some degree, even if you're saying, come into hospital, it's for your benefit. If they don't want to do it, you are kind of going against their wishes for whatever reason. And it is very to some extent, it's socially determined where that limit is, where that cutoff is for detaining someone. So it's very different in different kind of cultures and different societies, I think.
But in the same manner, though, I guess part of it is actually the reason why I went into psychiatry, in the sense, I guess I realized how vulnerable the psychiatry patients are. And I felt that actually being a psychiatrist was the best position to try and help them. Because I know we are coercing patients to come in or using the Mental Health Act, But I guess overall, I feel obviously we are doing it in the patient's best interest or for their benefit.
Mm.
And I think not doing that is actually more detrimental for the patient in the long run.
Mm.
So I guess for me, that is actually the reason that drove me into psychiatry, because I feel like there's this cohort of patients who actually, obviously, what I witnessed where I grew up, I felt really needed.
Mm.
But I think Ari is saying something that reflects my own experience as to why I ended up being a psychiatrist, which is that when I was at medical school, although I was moved by the suffering of many patients, cancer patients, patients with all sorts of very distressing and life-threatening conditions, it was people with psychiatric and psychological problems that moved me the most, whose suffering I most felt that I wanted to do something about. And I think Aria is saying something like that. But I also feel that amongst medical students, I noticed that many of them weren't moved by the suffering of people with psychological problems or psychiatric problems. It didn't have any impact on them at all, or very little. Do you think there's something different about people who choose psychiatry in terms of what affects them, what they empathize with, or what moves them?
I don't know about that, but I wonder if sometimes it's really difficult to allow yourself to be open to those sorts of feelings of empathy, and because sometimes to feel empathetic towards someone, you have to recognize that they are a person like you have a shared kind of human experience to some extent. And actually, in accepting that, then you can feel that empathy around their problems, but you're also opening yourself up to recognizing that actually people can't be put into boxes, and there isn't a clear boundary between mental kind of well-being and mental illness. And actually, I think that can be difficult sometimes for medical students to accept, or for anybody to accept, because sometimes there are quite stigmatizing attitudes towards people with mental illness, and accepting that could be you or somebody in your family as part of empathizing with that distress. I think that's can be difficult. So I wonder if actually sometimes people aren't open to it.
But I also think as a student, or when you're quite young, it's quite an emotional strain as well to try and understand that. Because I remember when I was a medical student, like I said, I was in camps and thinking, oh my God, this could have been me. And I felt really strained by it. And I think sometimes, whereas when you do medicine or surgery, example, if you're in A&E and resus, you kind of go into a rather clinical robot mode, and you detach yourself from the emotional aspect. Whereas in psychiatry, I think most of the time we don't. And that empathy and understanding is quite important, actually, to really understand a patient. And I guess that's some people are more naturally able to do that than others, and maybe it's people who are more naturally comfortable and able to do that go into psychiatry. That's just a thought.
I'm interested that both of you are still very clearly engaged with and excited and interested in doing psychiatry, because I feel that it's very different from, and I'm going to sound like a grumpy old man now, it's very different from when I started out, because the number of beds has collapsed in terms of the last 20 years or so. It's gone down dramatically, and the number of patients being brought in under a section of the Mental Health Act has gone up dramatically. When I started off as a junior doctor, I remember vividly my very first junior doctor job in psychiatry, we had several empty beds that stayed empty on the ward for weeks on end. And whenever we decided to admit someone, it was a very carefully constructed decision, and admitting someone did not involve having to discharge someone. So it was a very different environment to the environment. My perception is that you both are going to be practicing in, or are practicing in now. And I'm interested that stress of the lack of beds, the lack of resources, doesn't seem to have put you off in the way that it might do if I was thinking of choosing psychiatry now.
I guess in any specialty, though, you have to work within your means, and that it's not just in mental health that there are bed pressures, and actually this is the case in a lot of other specialties as well. So it is quite stressful, as in sometimes you feel, or sometimes I have felt like I'm not really happy that this person is remaining in the community. I don't think that this is the best for them, but actually because they aren't actively suicidal or about to kill someone, then we can't bring them into hospital because the bed pressures are such that it doesn't allow for, managing that. And that is in itself a stressful thing. But actually, I guess because there is pressure on working in different sorts of ways with people and on looking at alternative ways of treating people in the community, then actually I don't think that's necessarily a bad thing in itself, as long as it remains safe.
And I think there are big advantages of actually managing patients or looking after patients in their own home. I personally believe unless someone really needs to come into hospital, admitting them can be quite detrimental to their health in the midst of coping strategies, but more importantly about getting institutionalized. And that is to do with, losing touch or losing contact with your family members or regular contact with your family members because you can only have visits as often as a family can facilitate them. Or, I always think if I was unwell, I'd rather be in my own home environment than in a hospital, unless it was absolutely necessary for me to be in a hospital. That's how I see it.
But I guess if I would say if you've shown a certain course of illness, that when you start showing particular relapse indicators, say if you're suffering from mania and you're showing those, and every time that you've shown them before you've developed a serious manic episode which has led to you spending loads of money, getting into debt, putting yourself at risk in other ways, and actually I think in those sorts of, while you're still insightful and saying, look, I've got these, I think I probably need to come into hospital to have this managed, because, or even if you're not saying that, and actually what time has shown is that actually it can't particularly be safely managed in the community, I do think it's difficult to say, oh, actually we have to wait until you've done all those other much more risky things, or wait until further down the line when you've put yourself through those things, because actually getting back to normality is going to be much harder if you've gone through that episode, when actually that perhaps could be averted by various ways, certainly, but in certain situations sometimes I do think admission is indicated, and it's not something that we can offer.
I agree, and I don't think the stress puts me off, but the frustration really definitely does get me annoyed sometimes at work in psychiatry. But
I'm interested that both of you seem to be coping much better than I do with the frustration, because I think and again I'm willing to be corrected by both of you, I think there's a bigger gap between what doctors would like to provide in terms of treatment to their patients in psychiatry because of the starvation of resources than there is in other specialties. There's still a gap, but it seems to me, it feels, and I'm interested in your opinion, a bigger gap. Not just in terms of offering inpatient beds, but offering outpatient treatment in terms of the number of times you can see people, how long you can see them for, what other resources you can offer them in terms of other professionals and so on. So it feels to me that psychiatry is running in a much leaner way, which means you're less able to provide a satisfactory treatment than maybe you might be able to in other specialties. Let's say if you're a cardiac surgeon, though obviously there are resource issues in other branches of medicine as well.
I think, Raj, you're right when it comes to some specialties, but then in comparison to, GPs or even general medics, I'm not quite sure if we are so much more constrained than them, because every time you try to move a patient onto a general medical ward, you hear of them having to find a bed, but through that they have to discharge another patient, or there's however number of patients waiting in A&E that needs a bed. So I think actually it's a problem that's affecting every single specialty. And for that reason is probably why I don't feel too stressed about or feel victimized about it by being in psychiatry. And I guess whenever we speak to our friends, it's a common stress. And as a result, we cope better. That's why I think.
And I think because this is how it's been since we started training, we don't really know any different. So this is the environment that we've chosen to work in from day one. It's not like it's changed since we have started. So I guess those are things that we'd accepted before going into it to some extent.
But I guess for me, what really frustrates me is sometimes you don't get to see an individual patient and create a management plan specifically for that patient. I guess if you think of the pillars of medical ethics, more and more we have to think of the justice pillar. In other words, thinking, right, how can we serve as many people as possible with the X number of resources? And in other words, you're cutting down in what we can give to each person. Now that, to be honest, frustrates me pretty much on a daily basis.
Yeah, certainly on an individual point of view, it is frustrating when you want to, because obviously you always want to do more, and that's not available to you. Then that is frustrating. But overall, I don't think it's something that kind of would put me off doing psychiatry as a specialty, because I guess being a trainee, actually you're in a position, perhaps a naive one, that you feel, when I become a consultant, maybe I'll be able to influence things. But no, I think as a trainee you probably do. As a trainee in lots of things, you probably feel that way, and you think, in the future this is a challenge that I'll be able to influence, as something that I can improve in future. Maybe that's completely naive, but maybe that's why we're less frustrated than you, Raj.
well, I'm also interested in that I think that I personally believe psychiatry, properly resourced in the right circumstances, can be incredibly effective and incredibly powerful, but it gets confused. A psychiatry that's starved of resources cannot be as effective. But I'm interested that both of you have seen through the starvation of resources point to the power of the subject when it's able to be practiced properly. And I'm intrigued that you're able to see past that, because I think a lot of people can't see past that, and they mistake psychiatry, an underfunded psychiatry, with the real deal.
I don't think the stress associated with the resources, if it puts you off the subject, I don't think that's actually right, because whichever, as we mentioned earlier, whichever specialty you go to, you're going to feel that. But I think the bread and butter of psychiatry, the pure subject of psychiatry, at least I've been fortunate where everywhere I've worked, I have been able to deliver a safe care for my patients. I may not get the trimmings, but I can keep a patient safe. I've always had enough resources to deliver enough care that I know that the patient's safe, and I know I'm doing a service to the patient.
Also, I think that actually, perhaps choosing two psychiatrists for this discussion isn't the best way to get the view of the person who hasn't chosen to do psychiatry, because perhaps when we were, certainly my medical school experience of psychiatry didn't strike me as particularly underfunded or anything like that, or under-resourced. Maybe that's because I was just kind of blind to those issues at the time, or perhaps it was an area that actually more money does go into. But speaking to friends and colleagues in other specialties, under-resourcing isn't something that people particularly associate with psychiatry, but I guess it could, as you say, influence their perception of how effective psychiatry is at medical school. But to be honest, it wasn't something that particularly influenced me, and maybe that's because my perception was that safe care could be delivered as Aria says.
You see, that's interesting. I mean, I worked in London for a long time, and I don't know whether inner city London might be a bit different from the rest of Britain. And I worked in areas very near London, and I have to say I didn't think I was able to provide safe care for long periods of time, and that was very stressful. But we could obviously spend a long time discussing that point. But I want to focus just towards the end now on anyone listening to this who has been put off psychiatry. Maybe they're sixth formers studying A-levels or at medical school. What your thoughts are about why they should reconsider the subject. And what I'm particularly intrigued by is, I mean, I believe that people do get better, that psychiatrists treat, particularly if psychiatrists are able to offer the right treatments and the right resources. But what is different about psychiatry from the rest of medicine is you might bump into people at a dinner party who say, I went skiing and I broke my arm and the orthopedic surgeon fixed it and my arm's fine now. You very rarely meet people at dinner parties who say, I had a terrible bout of bipolar illness and I saw the psychiatrist and they treated it and I'm fine now. So in other words, the notion that people do get better and recovery is possible, and in fact recovery is very possible for most psychiatric illnesses, no matter how serious, given the right treatment, is something it's more difficult to get a handle on than in the rest of medicine. But both of you are therapeutically very optimistic, as I am. Again, how do we get that idea over to people who are not in touch with psychiatry?
I think a lot of it is around the stigma which surrounds mental health problems, because while there is stigma attached to it, then actually people don't want to talk about it and don't want to talk about experiences. And I think there's a lot of campaigns at the moment to encourage people to recognise that actually it is something that affects a huge proportion of the population, and it is something that we can do things about. And actually coming forward and speaking to your GP or telling somebody about the difficulties that you might be having, then actually that can be very beneficial for the future. And I guess as that message gets across, then people will recognise that actually these are things which can be treated, and as it becomes less, people feel less kind of shame, which I think people often do about having had a mental illness. And once it's more recognised to be like physical illnesses rather than like a failing of somebody's personal failing, then I think people will recognise that actually it is, you know, something that things can be done about, so that can be treated, and that psychiatrists play an important role in.
And I think as psychiatry becomes more destigmatized, I do believe it's rapidly becoming that, more you probably will start to hear people saying, you know, I had a rapid case of bipolar affective disorder, mania, and I went into hospital and I got treated by this really good psychiatrist. Actually, one of my more memorable bits in my career is I was at a function and someone actually came up to me and said, you know, you saved my life. And I have to be honest, this was 4 years ago and I still remember it, and really touched me a lot. And that was because obviously that person was very depressed at that moment and I'd seen the person in A&E. So we clearly, and that was, I mean, the person came to me after a couple of years after me seeing that person. So we clearly make a very big impact in people's lives. And we obviously, he or she as well. And I think the more exposure people have to psychiatry, the more any of the trainee, the students or the trainees in medical students would find out that actually psychiatry is very treatable, and we actually make a big positive impact on people's lives. And I genuinely do believe anyone who has the misconception that psychiatrists can't make a change are possibly students who haven't been exposed to enough psychiatry. Because all you need to spend is a few days on a ward to see the big change we make, or how well patients can be treated.
Aria and Amanda, thank you very much indeed. Thank you.
Thank you.
Okay.